flexible strategies. I have no idea what that means.
Nervous to see what you're going to say, but we'll see.
No, it'll be a very boring talk. Those are my disclosures. So let's first talk about nodular calcium versus non-nodular calcium. The first clinical cases of calcified nodules were actually IVUS cases published now almost 30 years ago in a small paper in the American Heart Journal. And you can see this patient presented with acute coronary syndrome. We thought this was a thrombus. It didn't resolve with any of the typical maneuvers to make thrombus go away. And this is an old IVUS. It's not great, obviously, but you can see the leading edge is calcified, and this was a large calcified nodule. In terms of prevalence, if you have severely calcified lesions, the prevalence of a concomitant calcified nodule is relatively high. It ranges from about 30% to about 40 to 50%. But if the patient is on dialysis, the prevalence goes up to about 60%. And if you compare outcomes in severely calcified lesions, those with a calcified nodule, those without a calcified nodule, you can see that cardiac death is higher in those with a calcified nodule, as is target vessel revascularization and stent thrombosis. The morphology of the calcified lesion is also important, and the worst outcomes are those with an eccentric calcified nodule or nodular calcium compared to the absence of a calcified nodule and just the presence of severe calcification. Now, calcified nodules come in two flavors: eruptive calcified nodules and non-eruptive nodular calcium. Eruptive calcified nodules are clustering of small calcium nodules with fibrous cap disruption, protrusion into the lumen, absence of endothelium, and overlying platelet and fibrin thrombosis, and is the third most common cause of an acute coronary syndrome, especially in older patients, with non-STEMI. Non-eruptive nodular calcium occurs within the plaque. It has an intact fibrous cap and does not involve contact of the calcium with the lumen. It's typically presented with stable angina rather than acute coronary syndrome. By OCT, this shows you an eruptive calcified nodule. You can see the spicules of calcium protruding into the lumen with shadowing indicating that there is fibrin and thrombus, while here is non-eruptive nodular calcium with an intact fibrous cap that's actually thick, and the reason you don't penetrate is because of the large amount of calcium. What about the prevalence in natural history? As I mentioned, in a patient presenting with acute coronary syndrome, an eruptive calcified nodule is the third most common cause, number one being plaque rupture, number two being erosions, and then you have a bunch of other things. If you follow the natural history of eruptive and non-eruptive nodular calcium, this is from the CLIMA registry by Francesco Prati, you can see that calcified nodules with disruption, the eruptive type, have worse outcomes than calcified nodules without disruption, the non-eruptive nodular calcium type. We have several series of acute coronary syndrome. This is one from now 7 years ago from Japan. You can see that there are three types of lesions causing acute coronary syndrome: plaque erosion, plaque rupture, and calcified nodule. And irrespective of the outcome modality, the patients with calcified nodules do the worst. More recently, the Taxus registry, also from Japan, again the same three types of plaque morphologies. The eruptive calcified nodule type did the worst, with an event rate of 30 to 35% at 1 year of follow-up. What are the patient characteristics? Patients with the calcified nodules are older. more often have non-STEMI presentation, more often have KILLIP class 3 or 4 heart failure, and are more often on dialysis. And if you look at predictors of calcified nodules in tactics, again, in all patients, it's age, KILLIP class, and hemodialysis. And if you're only looking at non-dialysis patients, it's age, KILLIP class, and diabetes. We're starting to understand how these evolve, or how these are created. This is a case from Takeshi Kubo, one of our former fellows. The proximal right coronary artery, you can see by OCT calcification with an intact fibrous cap. At follow-up, there's now disruption of the fibrous cap with an eruptive calcified nodule. We actually have a series of these that's now in press in neurointervention, and we looked at 372 untreated calcified lesions with a median follow-up of 1.5 years, and new calcified nodules were observed in about 7%. These were calcium with attenuation, larger amounts of calcium, a hinge motion in the coronary artery, longer duration, distal left main bifurcation, and again, hemodialysis. So as I said, we're beginning to understand the underlying morphology that is associated with development of an eruptive calcified nodule. What about PCI outcomes? Well, they're uniformly bad. I don't have to say anything more, but I will show you the data. If you look at heavily calcified lesions treated with rotablator plus stenting, the event rate for calcified nodules is about twice as high compared to calcium without a calcified nodule. And this is a recent study that's just published from Professor Ochiai's group in Japan. And again, eruptive calcified nodules have worse outcomes compared to the absence of eruptive calcified nodule. And what's most important is that, as I will show you more data, the reason for recurrence is that the calcified nodule reprotrudes into the stent. So here's the calcified nodule pre-intervention, post-intervention, and follow-up when the patient presents with in-stent restenosis. You can see deformation of the stent with protrusion of the calcium into the stent. We compared outcomes in eruptive calcified nodules compared to non-eruptive nodular calcium. And it turns out you get a better acute result when stenting an eruptive calcified nodule because you can displace these little pieces of calcium. But if you have a non-eruptive nodular calcium with an intact fibrous cap, it's very hard to deform this or displace it, so you get worse acute stent expansion. Now, the reason that's important is this is one of the few circumstances in which a better acute result, better stent expansion, is associated with worse outcomes. We're typically taught that a good acute result means you get a better long-term result. That is not true with calcified nodules. The eruptive calcified nodules get a better acute result, but a worse long-term outcome. Now, in terms of predicting the ones that do badly, this is also a study from Japan that looked at the morphology associated with the calcified nodule, and they had this concept of dark calcified nodules. Attenuation behind the eruptive calcified nodule was associated with worse outcomes. And the assumption is similar to what I showed you earlier. In untreated calcified nodules, this represents a deeper underlying lipidic plaque that contributes to a worse outcome at follow-up. So this is probably the only slide that addresses the actual title of the talk. This is unpublished data from St. Francis comparing IVL and orbital atherectomy in calcified nodules. And roughly the same number of patients in the two groups. Acute results are about the same in terms of final minimal stent area, and the outcomes are about the same. So we really have no great data on the best way to treat both eruptive and non-eruptive calcified nodules, because other than knowing that a good acute result is not a harbinger for good long-term outcome. What about in-stent restenosis and stent thrombosis? Here's an eruptive calcified nodule, here's non-eruptive nodular calcium, and here's a restenotic calcified nodule with reprotrusion of the calcified nodule into the stent. Most of the studies show that if you treat an eruptive calcified nodule and the patient presents with in-stent restenosis, the mechanism is almost guaranteed to be reintrusion of the calcified nodule into the stent. 80% in this series, 60% in this series, and 73% in this series. We also know that these happen early. So this is a study of ostial right coronary artery in-stent restenosis. And we looked at, or Akigo in this group looked at the time of presentation for in-stent restenosis after the stent was, after the lesion was treated. If you don't cover the ostium, they present very early. But a protruding calcified nodule occurs almost as early as if you miss the ostium. And then you get neointimal hyperplasia, stent fracture, neoatherosclerosis, and garden variety stent underexpansion. So not only are these recurrent calcified nodules inside the stent, but they happen relatively soon after the lesion is treated. And then stent thrombosis. This is something that surprised me. I did not realize that not only are in-stent calcified nodules associated with restenosis, but they're also associated with stent thrombosis. This from the real stent thrombosis registry, also from Japan. Okay, so you have a patient with a calcified nodule, you stent it, they come back with in-stent restenosis with recurrence of the calcified nodule. What's the best treatment? And the answer is I have no idea. So calcium compared to no calcium has a worse outcome. Calcium with a calcified nodule has a worse outcome compared to in-stent restenosis with smooth calcium and no calcific in-stent restenosis. So calcium does worse, and amongst the calcified in-stent restenosis, the presence of a calcified nodule has the worst outcome, and almost 100% recurrence rate at 4 years. Okay, so we're not going to restent them. We're going to use a drug-coated balloon, and the answer is drug-coated balloons do either as bad or as good, depending on your viewpoint, as restenting these. You can see that a repeat TLR is higher in the presence of calcified nodules, and if you compare drug-coated balloons to drug-eluting stents, the recurrence rate for calcified nodules is equally high. And here's a study comparing drug-coated balloons when treating in-stent restenosis with the calcified nodule with a recurrence rate of 85%. I'd like to finish with a simple case, maybe not so simple, a 45-year-old male who presented with diabetes, hypertension, smoking, and chronic renal failure on dialysis. Here's his right coronary artery, a focal lesion here, and you can see the calcified nodule protruding into the lumen associated with a lot of underlying calcium. The patient had stent implantation with a pretty good acute result, but stent expansion actually was pretty poor, only about 45%. 2 months later, the patient comes back, the lesion is back, and you see reintrusion of the calcified nodule into the stent. Treated with a drug-coated balloon, again, a pretty good acute result. Another 2 months later, and Here's the good result by OCT. You see that the calcified nodule has been displaced and stent expansion has been restored, but another 2 months later, and it's back with reintrusion of the calcified nodule into the stent. Treated with another stent at this point in time with a good angiographic result and a really good OCT result. 1 month later, the patient is back again and eventually went to bypass surgery. So, kind of a depressing talk because these are becoming more common as our patients get older, and I think probably a contribution of chronic statin therapy, as well as specific anatomic locations such as the proximal right and the distal left main. But I think it's a reality-based talk, because that's what the data shows. Calcified nodules, particularly eruptive nodules, are becoming more common as our patient population ages and more patients are being treated with long-term statins. While the acute results are good, the long-term results are poor, regardless of devices used during PCI. I've heard talk about trying to treat these with covered stents, but I have seen neither a case example and certainly not a series. The mechanism of PCI failure is almost always reintrusion of the nodule into the stent, and treating in-stent restenosis caused by reintrusion of a calcified nodule also has poor long-term results. Thank you for your attention.